Good afternoon, and welcome to this edition of HDSA and Me. Today, we welcome Dr. Erica Kristin Rapp, who will be speaking with us about perseveration. You can send a question at any time during the presentation. Just click on the chat function in the toolbar, type your question, and hit send. Your questions will be answered at the end of the session. This presentation will be available in about a week on HDSA's YouTube channel. On March 4th, we'll welcome Dr. Deborah Hall from our HDSA Center of Excellence at Rush University Medical Center. You can register for this session by going to hdsa.org/HDSA and me. And now a little about our speaker. Dr. Rapp attended medical school at New York University School of Medicine. She completed her residency and her consultation liaison psychiatry fellowship at Icahn School of Medicine at Mount Sinai. She joined the faculty at the University of Colorado School of Medicine, Department of Psychiatry in 2015. Here she is an assistant professor and the Consultation Liaison Psychiatry Fellowship Program Director. Her primary clinical work is as an attending on the University of Colorado Hospital Consultation Liaison Service and with the UCH HDSA Center of Excellence. In her work with people with Huntington's disease, she has become particularly interested in the treatment of perseverative thoughts and behavior. And now I'll turn the broadcast over to Dr. Rapp.
Thank you so much for having me today. This is a topic that is has become very near and dear to my heart. I am going to be talking about perseveration in Huntington's disease and its treatment. As you can see, I am very creative with the titles of my presentations. I was initially going to go with Perseveration in Huntington's disease, but given that this is HD and me, I decided to go with Perseveration in Me. I have been at the University of Colorado for about 5.5 years. I have a particular interest in psychiatric symptoms in people who have movement disorders. That's a longstanding interest of mine. About three or so years ago, I had the opportunity to start working at the Center of Excellence at University of Colorado, and I was very excited about that. In my work with people with HD and their families, I realized pretty quickly that there are some psychiatric symptoms that are quite well described. Of those, some we have some pretty good ideas about how to treat them. Perseveration is not one that falls into either of those categories. It's not particularly well described, although there have been some better descriptions in the past few years. And we have very little evidence about how to treat it. So that's why I really became interested in this topic. I'm hoping that I can kind of, that I can help patients and families and kind of the treatment community at large kind of start to figure this out and develop some better guidelines for treatment of this symptom. I'm going to cover a few different subtopics today. I'm going to talk about perseveration and what it is, and kind of there's the difference between obsessions and compulsions and OCD. I think that that's important to understand because they are not the same thing. They've frequently been conflated. But perseveration in my clinical experience is really quite different from the symptoms that people have when they have OCD. And it's important to understand the distinction because unfortunately a lot of the information that we have about treatment of perseveration in HD comes from the OCD literature. So that's why I talk about it. Then I'm going to talk about the recommended treatments for the symptom in HD, which, like I mentioned, the information out there unfortunately is pretty minimal. And then I'm going to touch on some information that we draw on from other neurologic and psychiatric disorders that can inform the way that we treat this symptom in HD. So first of all, I want to talk about what perseveration is. If you Google this, you're going to get a bunch of different definitions. The one that I want to focus on is this. It's you can read it. I don't need to read this to you, but basically, it's a repetitive thought or behavior, and this is the key, in the absence of an ongoing occasion or rationale for the behavior. So it's the more kind of plain language is it's the repetition of thoughts or behavior due to a cognitive inability to switch topics. And I think that is key, is the cognitive inability to switch topics. I happen to really like these 3D person graphics. So I have a couple of them here to illustrate. So this is what we want our thoughts and behavior to be like, sort of linear, kind of directed towards a goal. And this is what happens when we perseverate. We wind up running around in a tiny little circle and not able to kind of switch to different activities or switch to different topics. Sorry, I moved that slide. So I want to talk about what perseveration looks like, kind of some examples of perseveration that I tend to see in people that I work with. So one example is kind of excessive cleaning. So, or straightening, that can take a lot of different forms. You know, everything from sort of cleaning the same area over and over to kind of really very repetitively, you know, tidying different areas or kind of moving things around slightly even after the area is tidy. Another one that I see, and again, this can take a lot of different forms, is sort of organization or sorting. So this is a picture of some beads sorted in various different ways, you know, by color, shape, size. And what I see sometimes is people getting involved in sorting something, whether it be old photos or craft supplies or tools. Sort of there are a lot of different things that people can get involved in organizing and reorganizing, and what can happen is that they can get it organized and then sort of take it all out again and organize it in a different way, and this can take up quite a lot of time. So this is sort of an extension of sorting. I know some people who really spend a great deal of time going through sort of old photos or old mementos, and you know, obviously that's something that is that's wonderful to do, to kind of go through things that remind you of sort of pleasant memories of the past. But I know some people who are spending hours and hours a day going through the same photos or the same mementos, and that tends to kind of get in the way of them living their life. Another one that I see is sort of repetitive eating behaviors, where people will eat a meal and then just want to keep eating and eating and eating, you know, long after they've met their nutritional requirements. And of course, nutritional requirements in HD tend to be quite high. But even taking that into account, people who just sort of can't seem to stop eating or can't seem to stop thinking about food. This little cartoon is supposed to indicate just sort of in general kind of things that are upsetting. So I hear a lot that people with HD will get really focused on particular arguments that they've had with their spouse or another family member or a friend, and they will really have a lot of trouble kind of letting it go, or changing the topic, moving on to talking about something else, even days or weeks or months later. The other thing that I see with this is when something happens that is, very genuinely and justifiably upsetting, such as someone losing their ability to drive, or something else very upsetting happening, that people will get really, really focused on that, and they can have a lot of trouble kind of moving on from that. And, obviously losing the ability to drive, other things that happen as part of the disease are genuinely very upsetting, and we need to sort of work through them. What I'm talking about here is, again, to use the example of someone no longer being able to drive, that someone for really extended periods of time, months or years, will just focus on this all the time and will have a lot of difficulty talking about other topics. And then this one I think is really important to mention. I think that it can be awkward for people can feel awkward as individuals or couples bringing this up, but I really want to mention it specifically because it can be a real challenge for individuals and especially for couples. Sometimes people with HD get really perseverative about sex. And that is, when I'm talking about perseveration, I'm talking about a change from the way that they used to be. And that can cause a lot of difficulties for people. And that's something that's really important to talk about with your provider or your loved one's provider if it's happening. So next I want to talk about kind of the effect that perseveration can have on people and their families. I think that some of it is obvious. If someone is perseverating on kind of an argument that they had with their son a month ago and they're not able to talk to their son about any other topic, I think it's apparent why that's going to cause problems with the son. But it may not be quite so apparent why kind of spending time going through craft supplies or mementos is going to cause such a problem. So I wanted to touch on this. So one thing is that it can really take up a lot of time. I know people who spend hours and hours and hours per day on this to the exclusion of other activities. And you can be late for appointments, for family events. You can miss, I know people, I know a lot of people like to do kind of exercise classes. And, people start kind of missing their exercise classes, and that's so important in HD. So you can start missing all sorts of things or being really late for all sorts of things. This is sort of an extension of that, is that you can start not showing up to your life. You can start missing, missing time with the people you want to spend time with, missing doing things that are meaningful. So if you enjoy watching movies, you're likely not watching movies anymore. If you like gardening, you're probably not getting out into the garden. If you enjoy going to your kids or grandkids' sporting events, then you maybe aren't going, or maybe you're going, but you're sort of not fully present because you're preoccupied with this, with these repetitive thoughts. And then, of course, all of this stuff that you're missing out on, in addition to any kind of conflicts with family that are being caused directly by the perseveration, can really can cause problems in people's marriages and people's relationships with other family members and friends. So when I hear that someone is having some problems with perseveration, even if it's not that bad, I always want to try and nip it in the bud, because I don't want you to get to this last picture where you and your spouse are sort of at the point where you're really frustrated and can't even talk to each other. So I don't want to get too technical about what perseveration is, but I think that this, like from a cognitive standpoint, what perseveration is. But I like to give this example because I feel like it explains pretty well what sort of the cognitive aspect of perseveration. So this is something that it's a cognitive test. It's called TRAILS B. And what the test is that we tell someone to connect the dots. We tell them, and we get started for them. We say, go 1, A, 2, and then keep going. And someone who does not have problems with perseveration would say 2B, 3C, 4D. Someone who is having significant problems with perseveration can get stuck on either the letters or the numbers. So they can say 1A, B, C, D and skip the numbers, or they can say 1A, 2, 3, 4. So basically you get stuck on one on one particular kind of topic, and even when another topic is right in front of you, it's really kind of hard to see it and hard to switch. So I want to talk a little bit about obsessions and compulsions in the way that we think of them in psychiatry and OCD, because I want to kind of highlight how different it really is from perseveration in the way that we're talking about it in HD. So once again, I don't need to read you this whole definition. It's there if you want to read it. So obsessions are sort of the fundamental thing about obsessions is that they're recurrent kind of thoughts or images, fears that people experience as unwanted, as intrusive, meaning that you're kind of going along minding your own business and this thought just sort of comes into your head, even though you don't want it there. And it can be very distressing. So so to give a couple of examples of obsessions that we can see in OCD, we can see people having fears about germs or contamination. We can see people kind of being afraid of various kind of dangerous situations like leaving the stove on. We can see people having sexual obsessions. It's actually quite common in OCD. And then compulsions are the other main part of OCD. So that's repetitive behaviors and here's the key, they're performed in response to the obsession. So for someone who has an obsession about contamination, they might wash their hands repeatedly in an attempt to convince themselves that that their hands are clean. For someone who has sexual obsessions, they may, they may pray when they get the obsession to, to try and get it out of their head, or have another sort of mental ritual that they do to try and get the obsession out of their head. So, so that probably sounds pretty similar to perseveration that like I was describing in HD. But the key differences are illustrated in this slide. Sorry, it looks like the graphic is a little bit fuzzy, but hopefully you can read it. So this is a graphic that I like, the vicious cycle of OCD. So here in the upper right corner, we have sort of the first event, it's the obsessive thought. The obsessive thought causes anxiety. And then in response to the anxiety, the person performs the compulsion in an attempt to cope with or neutralize the obsession. And then that compulsive behavior does provide temporary relief. It's typically extremely short-lived, you know, a matter of seconds to maybe minutes, but it does provide some temporary relief from the anxiety that's caused by the obsession. So for perseveration, we kind of cut out numbers 2 and 4. We have, you know, some people have really perseverative thoughts, but often don't experience them as intrusive or unwanted or anxiety provoking. And they typically aren't performing compulsions in response to them. And people can have compulsive behavior, but they're typically not in response to anxiety. It's typically more like kind of a broken record. You're just sort of stuck doing that behavior. So I want to talk about what we know about perseveration in Huntington's disease specifically. It's not that much, but we do know something about it. So one of the challenges is that I see this changing in the past several years, but older studies on this topic talk about what I think is perseveration as obsessions or compulsions or OCD, or here, you know, on this slide, I mentioned a paper that looked at obsessive compulsive behaviors, OCBs. Now, reading those papers, I think that what they were picking up was perseveration, or at least a lot of what they were picking up was perseveration. But that is one of the challenges of sort of figuring out what perseveration looks like and how prevalent it is in Huntington's. But according to our best estimates, about 20% of people with HD have these obsessive compulsive behaviors. They can surface before a clinical diagnosis of HD, sometimes many years before. The best study that looked at the actual prevalence that I have found looked at people who are pre-symptomatic and then kind of looked at people throughout the course of the disease. So in pre-symptomatic people, they found a 7% probability of obsessions and 3.5% of compulsions. And then in people with advanced HD, it was higher, 24% and 12%. So you can see from these numbers that obsession, quote unquote, obsessions, or what I would call perseverative thoughts, are about twice as prevalent as compulsions, or what I would call perseverative behavior, which lines up with what I see clinically. So obviously it makes things hard. This is, you know, this is not news to anyone. It's something that sort of hasn't, so in medicine, when we want to bring attention to a topic, what we do is we do studies that show how difficult it is on people, and that's why I show this data, not to tell you something you don't know, but more to say there hasn't been enough attention to this topic. And the fact that there are so few studies that have looked at this, I think it shows me that not enough attention is being paid to this topic, because even if studies like this don't tell us anything surprising, it's still important to get that information out there to, you know, so that people can get funding for studies to look at it. There was one study that looked at patient-reported health-related quality of life. Of course, perseveration negatively affects it. There was a study that was a focus group study that asked caregivers what the most difficult part of caring for a loved one with HD was, and perseveration came up prominently in that. There was a small case series a few years ago that, now this isn't what we can call from a medical standpoint like high quality evidence. This was a case series where doctors talked to people who had made suicide attempts, who had HD, and kind of talked to them about what was going on leading up to it. And they reported that the patients had all said, all four of them had said that perseveration had played a role in their suicide attempt. So that's actually clearly very concerning. So of course, this is always the million-dollar question: what can we do about it? There is very little actual information out there to guide treatment. I'm going to talk briefly about what there is as far as medical treatment. There are a grand total on my last literature review of 3 patients who've had reported improvement specifically with perseveration. These medications, sertraline and fluoxetine, or Zoloft and Prozac for people who are more familiar with brand names, are both antidepressant/anti-anxiety medications. They're selective serotonin reuptake inhibitors. A couple of the older ones of the newer class of antidepressant medications, these are used in psychiatry in a lot of different situations: depression, anxiety, also OCD. There was one study that showed overall psychiatric and behavioral improvement, not specifically perseveration, but overall improvement with an antipsychotic medication called Zyprexa. There was an expert opinion survey 10 years ago now that asked people kind of what their clinical practice is. You can see that here. A type of therapy called CBT, which is a very common type of therapy in psychiatry for people who have minimal cognitive impairment or not having cognitive impairment. Then these SSRI medications. Clomipramine, which is an older antidepressant, antipsychotics like Zyprexa up here, and then anti-epileptics, which are in psychiatry, we call those mood stabilizers. And we use those primarily to treat bipolar disorder. But they can be used in other settings at lower doses, and this is one of them. Of course, there's always a question of like, what can you do? What can you do as the person with HD, or what can you do as the family? What can you do at home other than taking medication? And this is obviously a really important question. Unfortunately, it's not studied at all. There is some authors, one group wrote a paper that provides a lot of advice, a lot of different suggestions for how to deal with this. I want to pick out 4 from that paper. That this was not a study, by the way. This was just them writing about what they think is useful. But I want to pick out 4 things from there that I think are particularly useful. So, and these are really for advice for families and caregivers for people with people with HD that's a bit more advanced, where they're at least starting to have some noticeable cognitive impairment. So one is prevention. So if there are situations that tend to provoke the perseveration, such as talking about going for a drive, if the person can't drive anymore, if that's a topic of perseveration, then avoid that topic as much as possible. Redirection, I probably should have put first. It's probably the most useful suggestion and the most commonly used, I think. So what that means is that you change the subject. So if the person is talking about some subject repetitively, then see if you can change the subject. If they are engaged in a perseverative behavior in one room, see if you can take them to another room, see if that helps. This is sort of so the next one, that the idea of gradually modifying the activity is sort of an offshoot of redirection. The idea is that you join the person in the activity, but then kind of gradually change it to something different. And then finally, ignoring. So sometimes sometimes either the perseverative activity isn't really causing problems, or sometimes people actually seem to, particularly as their HD gets more advanced, they sometimes seem to develop some perseverative behaviors. It can seem like it's a way of kind of getting attention, or kind of getting their caregiver to give them something that they need. And if that's the case, then just not positively reinforcing that behavior, so just ignoring it, can help the person with HD kind of stop doing that behavior quite so much. I want to talk about what we know from other disorders about how we might be able to treat perseveration in Huntington's disease, since, as I mentioned, the evidence for treatment in HD specifically is not good. I'm going to mention a couple of neurologic disorders, and then OCD, which is a psychiatric disorder. So in frontotemporal dementia, which is a relatively rare type of neurocognitive disorder, you can also see very repetitive behaviors. SSRIs, so that category of medication that Prozac and Zoloft fall into, have been found to be effective in at least one small study for repetitive behaviors in this other neurologic illness. And then in people who have developmental disabilities, certainly not everyone, but there are some types of illness where people can have pretty repetitive behaviors. And clomipramine, which was one of the medications that was mentioned in that expert opinion study that I talked about a few slides ago, has been reported to be effective in some case studies in that population. So even if we expand our search to include kind of Alzheimer's, Parkinson's, where you see a lot of perseveration, other rare types of dementias like FTD, and you kind of really try and get creative for how to, for information about how to treat perseveration in, in people who have neurologic illnesses, is still not great. So that is why we wind up coming back to OCD. And this is the reason that I talked about the differences between perseveration and OCD earlier, because I think that even though we do rely on this to guide treatment, they're not the same thing. And I think that that's important to remember. So this is what we know from, and OCD is very well studied. The treatment for it's very well established. And the mainstay of treatment is SSRIs. So again, a category that Prozac and Zoloft are in, often at higher than recommended doses, which you may recall was exactly what people in that expert opinion study said. They said SSRIs often at higher than recommended doses. And then this medication, clomipramine, which is in psychiatry, that is basically only used these days to treat OCD because it has some significant side effects, but it is it's very effective for OCD. If that doesn't work, the next thing is you switch to a different medicine. So you switch to a different SSRI, you switch to clomipramine, you switch from clomipramine to an SSRI. And then we get really into the weeds of other potential treatments that have been reported to potentially work. I'm not going to read these to you. This is just to kind of give you an idea of that there are a bunch of other treatments that are used in OCD that we can potentially consider for someone who has Huntington's, who's having a lot of difficulty with perseveration. So that is a lot of, I know that I just threw a lot of information at you and that it's mostly medical information. I imagine there are probably going to be some questions about kind of coping with perseveration or, asking for additional advice on either coping with a loved one's perseveration or sort of helping them with their perseverative behavior. So I want to, let's see, it's 20 of. I want to make sure that we have a chance for those questions. I want to sum up sort of the informational part of my presentation by letting you know what my clinical practice is. So I wound up concluding that in the absence of any good information about how to treat perseveration in Huntington's specifically, or in neurologic disorders as a whole, that I agreed that the best we could do is draw on the evidence for OCD. So I tend to start these SSRI medications. I very often use Zoloft. It's a medication with few interactions. It's usually very well tolerated. I find that some people need relatively low doses of that. And some people I wind up going up above the FDA maximum. In addition to the SSRIs, a lot of people with Huntington's are on what we call, quote, antipsychotic medications, which is really a misnomer. They are, what these medications do is they block dopamine receptors, and that has multiple potential effects. It has an antipsychotic effect, but the reason that they're most commonly used, I think, in Huntington's is that blocking dopamine receptors helps with the movement disorder that's part of Huntington's. So I see a lot of the patients who I work with are on antipsychotics for their movement disorder that are prescribed by their neurologist. And if I want to make recommendations for perseveration for someone who's already on an antipsychotic, and I don't want to start a new medication, or the person doesn't want to start a new medication, then sometimes I will recommend just increasing the dose of that quote unquote antipsychotic medication. I find that it does not work quite as well as the SSRIs, but for someone, especially if their perseveration is more mild, it can certainly be helpful. I haven't had to go to these strategies that are on this slide that you're looking at now, with the exception that sometimes the person's already on one of these quote unquote antipsychotic medications. And sometimes I'll recommend increasing the dose of that. But I haven't had to go to these at the bottom here, which are really, I would call them more like third to fourth line. So that's been my clinical experience. I've had really good success with the SSRIs, and some success with, again, these quote unquote antipsychotics. So I want to wrap up there and make sure that we have a chance for questions. Now, I am not currently able to see the chat. So, okay. So if I exit from my presentation screen, then I can see the chat. Here we are. So one question that I have is, are there studies on effects of perseveration and quality of life, both for the caregiver and the person with HD? So the studies that exist are the ones that I talked about. It's not, it's possible that there are studies out there that I haven't found, or that, recent studies that I missed their publication, but I think we all know that perseveration has a negative effect on quality of life, both for the person with HD and for their family, and often for everyone around them. But we don't have any data, or we have very limited actual data on that. And then another part of that question is it typical for a person to have more than one perseverative behavior? That's a great question. I have found that people can have perseverative behaviors that kind of migrate. So not necessarily more than one perseverative behavior at any point in time. But although, I mean, it certainly wouldn't surprise me if that happened. But people seem to get stuck on one particular thing for a period of time, and then, maybe sometimes move on to a different topic of perseveration. So if someone is upset about their family taking their keys away, again, I keep coming back to that example because I think it's a good example of something that would be extremely upsetting to anyone. But sometimes I see people sort of get so preoccupied with it that it interferes with the rest of their life. So someone might have a lot of perseveration about that for several months, 6 months, a year, sometimes longer. But after that, that might sort of fade, but they might move on to another topic of perseveration. So what I've observed is that it's sort of one thing at a time, but that it can change over time. What I do see is that people tend to have, sometimes people just have perseverative thoughts. Sometimes people just have perseverative behavior. Sometimes people have both, not that frequently, but I see that stay relatively constant over time. If someone's main problem is perseverative thoughts, then they tend to have, whatever the topic, there always seems to be a perseverative thought. It doesn't migrate into perseverative behaviors and vice versa. I have another one, very intrigued by Knack as a third line treatment for OCD. Thanking us for that piece of information. Yeah, it's I haven't actually tried that in OCD. I'm in HD. I haven't gotten to the point where I felt that it was necessary to go there, but we have an OCD expert in an OCD clinic in our department. It's not me, but I'm able to benefit from it, and that provider finds that, I mean, it's not a medication that we typically use alone, but that added to other medications, when those aren't working well enough, that it can be really helpful. Next question is, how common is it for a person with HD to both be perseverative and unaware? That's another great question. Thanks for asking that. So yes, this is a huge problem, and I would say most of the time. So this sort of comes back to the difference from OCD, because in OCD, the reason that people come to treatment is because they're having these obsessions that are really distressing, and they're probably doing these compulsions that are taking up a lot of their time and getting in the way of them doing things that they want to do. And I think that probably one of the reasons we don't see that the distress aspect of these symptoms in HD is because people tend not to be aware that they're doing them, certainly not to be aware that they're excessive. When I talk to people who have perseveration, let's say, for example, a family member comes in and tells me, my wife just wants to, like, she wants to have sex all the time, like 4 times a day. I just, like, I can't keep up. And the wife who has HD will say, I don't think that I do that. I don't ask you that much. I mean, maybe like once a week, but that's what we've always done. So, so I think that a lot of the time people aren't even aware that they're doing it. And in some other cases, they know that they're doing it and they just don't really see it as a problem. So to use the example of, say, sorting craft supplies, which I keep coming back to because I'm thinking of an example of someone who has that. So for someone who, like, this person was always really into crafting and always spent a lot of time on it. It's their major hobby. And what kind of started to happen was that they stopped actually crafting and they started, so they when I would talk to them, they would tell me that they were crafting. They'd always done this, they really enjoyed it. I thought, great. Then when one of their family members talked to me, it turned out that they weren't actually crafting. They were just sorting supplies and organizing supplies repetitively. And so this person, they seemed to enjoy doing this, and they saw it as crafting, but their family felt that it was getting in the way of family time, and it certainly got in the way of getting to appointments, and it was hard to engage this person in anything else. So, but the person with HD themselves didn't realize that this was happening. So I mean, those are just a couple of examples, but in answer to that question, how common is it for someone to have to be perseverative and be unaware, I would say most of the time. I have not seen people with HD who are perseverative and are aware of it on anything more than sort of a very vague level. Like, yeah, I know I spend a lot of time crafting, I'm sorry about that. It's just something I really enjoy. So this person recognized they were spending a lot of time on it. They just didn't recognize it as like a perseverative, unproductive behavior. All right, here we have another question. Yes, we have a shy audience. Please ask questions. Okay. How do you get someone who has sorted their supplies over and over and taken over the living room and can't seem to be able to do more things to another place so the family can gather? Yes, that is a great question. So it sounds like this has gotten to a point where so if someone has kind of taken over a room with whatever they're sorting, it's probably gotten to a level where that person would benefit from some medical treatment. It's hard to give, it's always hard to give advice in this type of setting because so much depends on the specifics of, of an individual person with HD and their family and what their family's goals are and what the person's goals are. But I would say just sort of as a general statement, when something is really sort of affecting a person's life or their family's life, I would really strongly consider talking to their physician about medical treatment. If that isn't possible, or if it's, if you're trying it and it's not working or not working well enough, then there are some strategies that could potentially be helpful. One is this idea of sort of redirection by joining in and gradually changing the behavior. So this can work sometimes if you can sort of join the person in their craft supply organization, but then sort of redirect it towards organizing it in a different way. So instead of organizing it all over the living room, could you organize it in drawers? Or could this person organize something else? If craft supplies are sort of taking over a main room of the house that the family wants to gather in, then is there, can this person be sort of shifted away from organizing craft supplies and shifted towards organizing something different? And this does typically have to be pretty gradual. So we're not talking about over a period of minutes or hours. We're talking about a period of, over a period of days or much longer. But the idea is to sort of gradually introduce other things to organize, or a different way of organizing those craft supplies, and kind of gradually shift the person away from that particular behavior that's getting in the way of family time. Hopefully that answers the question. What other questions do we have? We still have a few minutes. No one else?
I think we have a very shy audience today, and or you've answered every question they could possibly have thought of.
Every question that's out there.
Every question out there. So in the few minutes we have left, is there anything that you would like to touch on again that you may have skipped over, or given just a brief period of time because you were trying to make sure we had time for questions?
I think that the main take-home point that I want to send people out with is that if this is happening, it's really important that you talk with your provider, because it's not something that tends to get better on its own. It's something that once it's happening, it tends to progress. Which is not to say that everyone with progressive perseveration has a complete disaster in their life, but once it starts happening, it does not tend to go away on its own. It tends to get worse. So if this is happening, it's really, really important to nip it in the bud. That's not to say that it can't be treated after it's progressed. It's more difficult. If you can nip it in the bud, that is ideal.
Okay. We do have a follow-up question here. How do you do that with flat out denial?
So yeah, that's challenging. When you're talking to the way that I'm interpreting this is in terms of like, how do you talk to the person's provider about it if the person does not believe that there's a problem? Please clarify in the chat if that's not what you mean. So I typically try to, at least the first time that I'm meeting someone, to talk to hopefully someone comes with them to the appointment. I try to talk to that person separately. It doesn't always happen. Sometimes just because of logistics in the clinic schedule, it becomes really difficult. I try to do it, and I think that's kind of the ideal way to address it, is to talk to the provider separately and say, you know what, this is really a big problem, and I really want to try to address it. There are also ways that, you know, you can call the provider and to have a private conversation with them. You can, there are also ways that you can let the provider know, even if you're having a conversation with the, you know, in the same room with you and the person who has HD and their provider, that there's an issue. And people do this for me, like caregivers do this for me all the time, where I say, so, you know, how do you think that things have been going recently? And the caregiver might say something like, you know, well, I know that Dave Dave thinks this is better, or Dave doesn't think this has been as much of a problem recently. I've noticed that he has still been spending some time sorting through his old photos. If the person, you know, and then, you know, Dave might say, oh, I haven't been doing that recently. And you might say, no, yeah, I mean, I know that you disagree with me. I'm just, you know, your Dr. Rapp asked me how things have been going, and I'm just letting her know what I observed. And that lets me know that the perseveration is a problem. So that's the kind of thing that you can do if you're really not able to talk to the provider privately. But, you know, I know that it can sometimes feel yucky. It can feel like sort of going behind the back of your loved one. But the reality is that unawareness, it's a big problem in HD, and sometimes it's better, rather than sort of having the argument, to let the provider know what you're observing. And if the provider recommends a medication, we can often sort of cajole the person who has HD into taking it by talking about other symptoms that it's going to help with. So maybe someone's a little depressed or a little anxious, and that's what they see as the problem. You see the problem as perseveration, and they don't agree, but they do feel that they can get kind of depressed or kind of anxious. You know, sometimes we can convince them to take the medication that way. Sometimes, so I've had some patients who say, you know, I don't want to take this. I completely disagree with my caregiver that I'm doing this at all. And I'm able to convince them, like, you know, it sounds like you and your caregiver are having a lot of disagreements and a lot of conflicts. It sounds like things are unpleasant. Why don't you just try this and see if it helps your relationship? And in a couple of cases, I've had that work, and have people come back and say, you know what, I don't think that this is doing anything for me from the standpoint of perseveration or mood or whatever. But my relationship with my caregiver, like, we are getting along a lot better. And I'm willing to continue to take it because I think that it helps me get along with my caregiver. And that's really nice. So I'm definitely not saying that works in the majority of cases, but it is a strategy that we can use. Typically, we try to get the person on board with taking a medicine by kind of describing how it could help address the things that they are concerned about.
Thank you. That was terrific. We are out of time, so I would like to remind folks that this presentation will be available in about a week on HDSA's YouTube channel. I'd like to thank Dr. Rapp for taking the time today to talk with us about perseveration, and we invite you to join us on March 4th when Dr. Deborah Hall from our HDSA Center of Excellence at Rush University Medical Center will be joining us. Thank you very much and have a good day.
Thanks so much for having me.
Bye-bye.